We will get started with our webinar. I'd like to welcome our panelists, Emily Warr and Christie Musser. Hi, Christie. Hi, Emily. Hi. Thank you both so much for being here, and thank you for everyone who's in attendance. We do have quite a few registered, so we may see other folks popping in along the way. But if you have any questions that you want to ask during this webinar, we like for them to be interactive. So please feel free to put them in the chat. We'll be happy to answer questions along the way. I'm not sure we'll be, solving world peace here today, but we will be bringing up the issues and some solutions that folks have found, and some challenges that folks have found, and hopefully start the discussion around what is happening in this industry. So I'd like to welcome Emily Warr. She's a nurse and the administrator of Medical University of South Carolina's Center for Telehealth, which is a HRSA designated Center for Excellence. In her role, she oversees the strategic goals and direction of the telehealth initiatives in South Carolina, as well as the quality of service delivery of statewide telehealth activities. As well, we have Christie Musser from St. Luke's, who is the Senior Director of Virtual Care and Patient Experience. In her role, she is focused on digital transformation efforts to improve clinical communications within the care team and leverage technology to connect patients to the right care and right person at the right place and the right time. So welcome to both of you. So let's get started. Let's talk about the first elephant in the room. How has the telehealth industry changed since the pandemic relative to providers and provider recruitment? And Emily, I'll let you get started first.
Oh, sure. So a lot. How has it changed? Well, it's changed a lot. I mean, I think there from where I sit, that's a very positive thing, because and on the one hand, because providers have learned a lot about what they can do via virtual care. I think there even some of our sort of most transformational providers and cutting edge providers may not have really known prior to the pandemic what all they might be able to do via virtual care and assessment of patients and sort of in a longitudinal way. And so the pandemic gave us a great opportunity to figure some of those things out, because we had to. And on the other side of that, I think what it's led to is a sort of providers' eyes are open to the possibilities. And so there's a sort of a disruption in the market and what providers are willing to do and want to do. And also, I think sort of a glimpse of the flexibility that virtual care could bring to their own practice, including where they practice.
Absolutely. Lots and lots of flexibilities there. Any thoughts, Christie, just in terms of what you've seen post-pandemic?
I spot on. I think that there's, I think that statement is the positive and also that elephant in the room, right? It's that we've realized what we can do, and that's great. And we've realized what we can do, and that's presenting bringing some challenges in, because there is more flexibility, right? And so we talk about provider well-being and burnout, and how this can really potentially provide some work-life balance.
Right. And I think that's one thing to consider, right? Everyone's a human being with life and problems and those types of things, and family and life changes happen. So we can't blame the physicians for taking on flexibilities of work. That's actually a good thing, considering the Great Resignation and the burnout that we've experienced through the pandemic. I read an article recently in the New England Journal of Medicine, and they said that in one company that's doing virtual care, up to 10 to 12 physicians are seeking employment with them every week. And that is a hefty number when you start to look at all of the different recruiting companies that are out there. I do see that we have one fan of yours, Emily, as a Gamecock, but also Iris Berman is raising her hand. So I would like to see if I can allow her to talk. This will be an exercise in my abilities of Zoom, if I get this right. Or the other option would be Amanda, if you have the ability to do that, is listening, or maybe she. Iris, I just allowed you to talk. If you were.
It was me fact fingering. I didn't mean to interrupt your discussion. I am so sorry. I was actually going to put a question in the chat, but when you say that it's also the negative, there's a certain amount of innovation. I'm just curious if you can get a little bit more specific around that. I mean, certainly we're talking about the doctors that might be migrating away from our traditional care scenarios to these outside agencies, which we're certainly seeing where we are as well. But are there other things that are rate limiting to you within your organization that you are very watchful of?
Absolutely. I'm going to add to that before you answer that question, because it is part of our discussion, and I'll take you off of the list here, Iris. I apologize. But the one thing that we did talk about even off screen was around this idea that organizations, third-party companies, as Iris referenced, they are addressing the needs from consumers who want to receive care when and where they want to. But how does that affect population health management and the issues that Iris just brought up? And Christie, do you want to start?
So that continuum of care, and Iris, I want to go back quickly to your question. Internally, just an anecdotal story. Our chief medical officer had the rheumatology physician come and say, listen, I've got a sick child at home today. Either we're going to have to cancel my entire day or I can work from home. And he's like, all right, then you're working from home. And so I think those are the kinds of flexibilities that now physicians are seeking within the organization. So we as organizations have to determine what our policies and procedures are going to be around that. Otherwise, we're going to lose them to places that offer that flexibility. So around the disruptors that are coming in, I think from an organization standpoint, I think it's helpful in spurring us on that we have to respond. Now we're not going to be able to not respond, but I think there is concern that it's going to further fragment care across the continuum, right? So as we as integrated health networks have really worked to build up that longitudinal care across all service locations so that you feel like you are not just having transactional relationships, but really developing relationships over your lifetime of continuum, that this is going to create convenience that patients will flock to, we think, that will take them away from where they're going to need that in-person care. So it's how do we reconcile that? How do we realize that, maybe we can expand some access with these telehealth providers, but how do we as organizations either partner with them or create those pathways that patients find attractive with them and do it as well as them, which as healthcare organizations, I'm sure we all know, creating that digital seamless strategy is doing it like Amazon is probably seems like an impossible task, but I think that's what we're looking at. How do we solve that? How do we compete with that or join them?
You compete. Exactly.
Yeah.
Exactly.
I think the partnering element is really important, right? I think, there is a role, and there are a lot of patients out there that need to be seen, right, and helped. And so there is a role for a sort of bigger platform solution like, an Amazon, but there's also, I think, a role for partnership and sort of the local health systems and community providers to partner with the bigger groups and see the patients locally when they need to be seen, whether it's via virtual or, pulling them into, we stood up a rheumatology virtual clinic, for example, and patients need infusions. So we're connecting with those, brick and mortar locations that along the continuum, the patient needs to be engaged with to make sure that the patient doesn't fall through the cracks. I think that's the biggest one of the biggest risks with these big sort of national providers coming into the space is that fractured care that Christie was referencing. And I actually think local providers and health systems are really well poised to solve for that. I don't know that we should go at this from trying to beat Amazon. That's a big monster to beat, but partnering with and figuring out where we fit in the space to be able to serve our patients ever better is sort of the right way to approach it. I do think that the monsters coming into this space are going to make us make those decisions more quickly, which is ultimately going to be good for the patients. Back to Iris's question, just one other comment. I've noticed there's internal disagreement about what the value of virtual care is for our organization, and particularly in the College of Medicine. I'm in an academic medical center, and the departments and divisions, and how they, in particular, their specific needs can be met via virtual or not. And so we've had to take sort of a disruptive stance and hire physicians for totally virtual practice outside of the department, which has been disruptive internally and caused some discord. So the disruption is here, and we're all figuring out how to deal with it.
So that's a really interesting point, that you've specifically hired folks that are 100% or whatever percentage they are only doing virtual care. Because I also saw that Dr. Kavader had done a study post-pandemic. Dr. Kavader, for those who might not know, is the prior president of ATA, and is at Harvard. But the study that he conducted was around it was for the Healthcare Coalition Impact Study Work Group, and in that study, and I've got it to my side, so I apologize, I'm looking away from the screen. But in that study, they showed that telehealth and telehealth claims increased 50 to 100 times in several US states between, obviously, during the pandemic, obviously, but then significantly grew in all states post-pandemic. And as part of the companion, found that even the percentage of physicians that had engaged in telehealth was increased up to almost 85%, which was, astronomical compare, which we all are aware of that based on, but what we've seen is the numbers have gone down. However, we've still not seen the demand from the public going down. So from a consumer perspective, are we now going to need to think about, and I've really got two thoughts there. Are we now going to really need to think about having this taught in the medical schools around website manner, and those that have a better website manner will be hired into this telehealth space, or will we need to look at the physicians that are providing care and having some kind of a hybrid model? And I would put pressure on the third-party providers as well to have this connection with the community. So I don't know, I've got a lot of pieces and thoughts in there, but Emily, I'll let you start, and Christie, I'll let you follow up.
So with regard to the education piece in the colleges and universities, and at the postgraduate, the GME piece of it, residency, et cetera, I think it's critical. It's not the future anymore, it's the now. And so we should be training our residents to be able to engage with patients in all the different ways that we are now and will be in the future. And so that's, that is synchronous video, that is asynchronous remote patient monitoring, working more collaboratively with care teams, incident to billing through a team of nurses to do remote patient monitoring work, those sorts of things. They're just different ways to care for patients than traditionally have been taught. So I think it's imperative that we are training the workforce of the future, and not just physicians, nurses, and other providers, to figure out how to engage with patients in this way along a continuum, multimodal engagement. So I think that piece is certainly important. You mentioned hybrid care models. It's something that we've dabbled in and been challenged by, I'll be honest. I think one of the lessons learned for us in hybrid models is that it really helps to block a schedule. It's very difficult for a provider and a clinic to sort of pendulum back and forth between virtual visits and in-person visits. They tend to run behind. The team is trying to manage patients that are there in front of them and those that are at home with some technical difficulties or whatever it is. So what we found works is actually blocking schedules. But I think ultimately, fast forward 3 or 4 years, hopefully sooner, you'll actually see sort of designated days of the week or times of even quarters, whatever it is, where you're working as a virtual provider versus an in-person provider to gain those efficiencies that we know are there. Because otherwise, I think neither works as efficiently when you're trying to sort of meld them together. So the hybrid model is important, but figuring out sort of best practices in that model to make sure that it's efficient is important.
Yep, absolutely. Christie, additional thoughts there?
Oh my gosh, I completely agree. And it's that finding that right operational model around hybrid care and what that looks like. And we've gone through those same struggles. And I think that's the internal pieces, right? You have some physicians that just are not going, they're not bought in now and they're not going to buy in. And it's how do they continue to see patients efficiently? You know, the question is, do we force them or do we start to centralize our virtual care offerings? Because you're right, I don't think that there's, you know, we talk about efficiency, but it's only efficient if it's strategically, you know, created and operationalized. Otherwise, it can actually have the opposite effect, and that's what we saw. So we actually moved in our urgent care space. It lived in our physical brick and mortar urgent cares, the virtual piece. However, it was basically other duties as assigned to treating, you know, so you're treating in person and those people in front of you, that always came second. So we realized that not going to work. We need educated, and we're finding that more. And I think that then determining and figuring out where those best practices are, sharing them, knowledge share between our organizations, and then making sure that the physicians of the future, and like you said, totally understand and think that that's the way to go, is that we need to be educating not only physicians, but nurses. And honestly, I'm going to say the entire organization, how we communicate with patients is changing. And so from a patient experience standpoint, I come into how we communicate in person. We have to think about the fact that we're now going to be communicating with patients via text, potentially email, portal. What is that etiquette? What do we need to set expectations around with patients for? And then how do we as employees, whether administrative or whether the frontline, you know, medical assistant, MR, whatever, when you're communicating with the patient digitally, what does that look like? What are best practices in that space as well?
Right. I think this best practice thought and these clinical guidelines that you sort of alluded to, Emily, are super important now. And I would encompass nurses in there, especially with the advent of virtual nursing and the Great Resignation, of course, applied to them as well. We're seeing a shortage on both sides. We have several questions in the chat that I'm going to jump to while we have time. What role can technology play in making telehealth and telemedicine more efficient? Can you please provide some technology examples healthcare providers are using today other than Teams and Zoom? Without endorsing any particular one, but you can certainly say what you're utilizing at your facilities. Go ahead, Christie.
Sure, I can. There's so many. I mean, the use cases are just endless. I think we actually are heavily invested in looking at the inpatient space because we have one medical staff that covers 12, 13 hospitals across spanning 2 states and 9 counties. And don't quote me on those statistics. I think it's constantly changing. But we need to connect, you know, one medical staff covering all these places. And so you have a lot of travel, a lot of windshield time. So we're really looking at how technology can connect the care team and not just a physician consult, but how can we connect patients and physicians prior to maybe a transfer? How can we look at what dietary services is now doing in person and potentially consolidate that? I mean, there's a shortage of openings around our dietary services. We just can't, you know, get people in. So how can we make that more of a remote service? But what we're doing is we're putting it on the TV. We're putting in big screen TVs in the rooms. So when the provider or care team member or pharmacist or whoever it may be comes into the room easily through the Epic platform, because we have to make it easy for the care team as well. It's more life size. It's more lifelike. So we're creating that lifelike experience, even though it's virtual. So we're really working on that in looking at the reduction in windshield time for providers, the ability to see more patients across the network, because right now you're going to be limited to that travel time, you know, the travel time between places, and then how we can look at it as a workforce optimization strategy, just because you can do more. I won't say with less, but you can take one person who can cover a broader scale, especially if you have smaller hospitals throughout. So we're really focusing on the inpatient technology there, and I think there's unlimited use cases in the ambulatory space and beyond. So I don't know if Emily wants to take on a couple of those.
Yeah, well,
increase?
I mean, that's a great point, and you focused on some of the hardware elements. I think one of the emerging really important software focuses is on sort of care team collaboration and workflow facilitation. The video client is good. All video clients have their quirks. You kind of choose one and you stick with it, and you work through it with the vendor, and you get the sort of kinks worked out, and everybody learns how to use it. I think the bigger picture is about facilitating some of those efficiencies that Christie was describing around care team collaboration, bringing the right provider, the right nurse, the right care team member, whomever they are, into the visit at the right time for in the appropriate context with the appropriate patient, if that makes sense. And so there are some vendors that are a little ahead in that space, thinking about how healthcare is care teams. It is the right people with the right experience and specialization being pulled in at the right time to the care of the patient, whether it's in the emergency department or in the ICU or in the ambulatory setting. And then also sort of leveraging some of those workforce and workflow tools to pull elements out of the chart. You referenced, live and being embedded in Epic or whatever your medical record is. I think some of the tools out there in the market now are really learning how to leverage what's already in the medical record and pulling some of those elements out, and even into that workflow navigation that pulled the provider in and the information out of the chart to the provider, to be able to manage very efficiently the situation that's in front of them. And so that's what I would suggest from a software standpoint that folks need to be thinking about, is how to best and most efficiently use the most valuable resource that we have, well beyond a video client or the technology that you put in the room that you'll have to change out in 3 years, but it's the people and how they interact with the patient in a timely and informed way.
Absolutely. Yeah, I think this idea of communication and increased capacity is important. Go ahead, Christy. Did you have more to add to that?
Yeah, I wanted to just add that communication piece, and it's now it's with the patient and it's also within a care team, and I think we're learning a lot of lessons in how we communicate effectively within the care team as well. We've gone through some transformations so from a technology standpoint, right? So we talk about patient facing, but also care team facing. And so your secure communication platform, your collaborative platform that you're using, how do you, I know we've seen some efficiencies in developing a role-based self-serve communication system within the care team. So it connects everyone. I think that's something that's really made us more efficient. So now I need to discharge a patient. I'm a hospitalist, but the EKG still hasn't been read. I just need that final rate. And how can I quickly get a message to that cardiologist, have them, oh, let me try that, and then we'll get this patient moved out, just impacting that throughput rate. So those are some small examples, but really gaining that efficiency in the care team. It's going to be people and process are going to be huge. The technology, I think, is important, but it's a small part of really making it work.
And honestly, it's sometimes the easiest part of the three that you talked about. So another question, we have an active question and answer. Creating skills and competencies around technology and communication. They agreed with that. We have competencies for nursing, camera etiquette, but we also need to work on health literacy for our clientele. How do you account for differences in social determinants of health and technology literacy?
So important.
On that, Emily?
Yes, that is something that we're really trying to focus on. It's another sort of potential pitfall of move into this next sort of era of healthcare and digital engagement, is that we could exacerbate these disparities that are already present because of the availability of technology or digital literacy on top of health literacy, right? So it's something that we're trying to think about every day. In fact, we're talking with our leadership team about hiring somebody who that would be their focus, actually, is how each one of our programs and platforms is thinking about the user experience and digital literacy, and how to train up our patients on how to use it, sort of engage with their providers in this way. in a proactive and sort of equitable way. So I think it's really important. It's easy to sort of lose sight of that because in the otherwise complex environment of the things that Christie just talked about, you know, the people and the process, and then the technology as well. But I think we should keep our eye on the ball because it's really of critical importance to make sure that health literacy and digital literacy and sort of the equity component are not overlooked here.
Yeah, and I know personally that there are some programs that are out there that are targeting seniors in particular. That's been going on for some time, coupled with the senior centers and other senior organizations that are out there for digital literacy. But that is not limited to seniors that have digital challenges. So we really don't. I often talk that we should have a PSA for telehealth and explaining to people that this is not substandard care and it is a good thing. Anyway, go ahead, finish comment, Christie.
It's very interesting you said this not substandard care. We did a survey of the community around telehealth, and I would say by and large the biggest barrier, not so much the technology, but the perception that the quality is less. And so I'm like, all right, then our focus really needs to be around education, the literacy, not only how to use the technology, but that it is safe and comparable to in-person when it is, right? There's certain things that are and there's certain things that are not. And I think it's on us to really get out into the community. I know we have personally been going to various senior communities and, you know, just doing in-services when they come together and answering questions, showing them what's possible. That's not sustainable at a large scale. However, those are the kinds of things within the communities that I think can be done to address those disparities. The other thing we're thinking about and we continue to toss around is in locations where you have a larger population that doesn't have access to broadband or phones, even smartphones, is creating centers where patients can go that in their community to have visits with specialists that are further away. So that they still might have to travel some, but it's still we're keeping them in their community and getting them more access to specialty care.
I found that's been happening quite a bit in the library systems, right? On some states versus another more so, but libraries seem to be expanding their purview of education and learning and providing some private spaces. Okay, so we have 2 more questions related to kind of telehealth specific, and then we'll talk again about providers and some of these balances. But one question around, do you consider RPM to be telehealth, and we have a big nod of yes. What about hybrid in that patients might use RPM and then have an in-person visit versus defining from the provider point of view? Yeah, big nods on that one.
Yeah, so yes, we consider RPM to be telehealth. Definitely, it's a sort of digital engagement along a continuum of a patient. We think it's. I actually believe that we have a long way to go on the reimbursement for remote patient monitoring. I think the codes are pretty rough for the amount of work that it takes. It's a lot of additional patient engagement, and the codes are sort of subpar there. But we're working on that with advocacy, and I think we've got to show that it can work. With regard to hybrid or needing to be seen in person along the continuum for a patient that is monitored remotely, from a billing perspective, you just bill it as a separate type of visit, but you have so much more information when you do come in person, right, about the patient's blood pressure or glucoses or whatever over the course of the last 2 months to be able to manage. And I do think we can likely, we'll have to learn, but I do think we can likely have more sort of virtual types of visits, synchronous virtual visits, without having to bring patients in when we have access to sort of reliable biometric data within the home. So, important questions, and particularly as we talk about sort of educating the patient and helping them understand, am I going to be, triple charged for these things, or does it make sense to have all these different types of engagements? I think we have to figure out what's appropriate and then help the patients understand how we're adding value.
Exactly. And I think we also need to educate the the payers as well, to help them understand the complexities and how to understand how these work, so that we don't see the pressures that we're getting from our original, point of the conversation, which is the battling of providers here, the recruitment battle. We see sometimes these providers are being recruited out for 2 and 3 times what you could pay in a community health center, where they are actually providing for the most vulnerable populations, and particularly in the behavioral health space, where LCSWs, et cetera, are so needed. They are impossible to come into these community health centers, where there's not a prayer that they could pay that number under the current fee schedules and under their current funding processes that they do have. So what options are there for community health providers to retain and recruit these patients or these providers, in this changing world? What are your thoughts about that, Christie?
So I think we have to consider what they can get elsewhere. So we have to make sure that we're aware of the, what's being offered to them in other care settings, and what can we do to potentially accommodate that, or to create something where they have more flexibility. And I think we're seeing that in all roles, not just physicians, but in just recruiting in general for nurses, even our MRs and MAs. We're pulling out what is the stuff that can be done virtually and remote, and providing a more hybrid for the providers as well. So, we talk about hybrid care for the patients, but then hybrid work for providers and care team members. What does that look like? I think we also have to make sure that we're providing adequate resources and support. So not just, for those that may want to do more in person, we're not just forcing them to do telehealth, but we're offering them a balance. Or if they prefer to do only telehealth, that we look at what kind of positions do we create or need in that world that will complement the care team. So I think it's really making sure that we're keeping pace with what's happening. What are the offerings and the benefits that these providers are getting with these other companies that we could potentially put together that would be more attractive as a more holistic package than just doing a transactional service with a telehealth company.
Yeah, good point.
You're also building relationships. I think that if providers are they want to build relationships over a continuum, they're probably going to want to do more of that hybrid care or be in a community setting. So I think we have the advantages. It's just making sure that we recognize that providers want and will need, and again, not just providers, the whole care team is going to need and want that flexibility.
Yep. We just got to keep, I think it's an opportunity to retain your best providers by being, aware that we need to offer some of those flexibilities. And it's true at the bedside, it's true for our physicians and APPs, but it's also true in the workforce that's supporting those folks. We have a hybrid work. I'm sitting in the office today, but sometimes I'm able to work from home. And that flexibility is something that in the post-pandemic world, people expect. And I think it's fair to expect. And so we just can't fall asleep at the wheel on that. We got to, step up and recognize that those flexibilities are the norm now, and we need to figure out how to make them work within our business models and our sort of missions to help our patients. I think the other piece that you touched on, Christie, and we've talked about a little bit before here, is partnership. If your provider group really wants to continue to see patients in person or wants to, lean more virtual, then making sure that the partnerships to sort of fill any gaps that would lead to are sort of pioneered, whether they're national partnerships or local partnerships. I think that that's one of the benefits of this, again, brave new sort of era that we're about to or endeavoring into is the ability to really leverage the best and brightest from all over the country. And so we shouldn't be afraid to start having those conversations and partnerships and finding a good fit to serve our patients in really innovative ways.
Yeah, absolutely. And there's a whole other webinar on how to manage those virtual staff as well, and how to change your management styles when you have virtual and brick and mortar or homebound or on land staff. So turning back to a couple more questions that we have in the chat concerning interoperability. Emily, you had a comment about pulling in the right specialist in the care team as needed and expanding that capability via telehealth. How do you manage that when the providers might be utilizing two different EHRs?
Mm-hmm, mm-hmm. So interoperability is really key, and it's and it hasn't, as a Center for Telehealth that's been around for about 13 years, we started without any of that and just had to figure out how to cobble it together, and we truly have come a long way. So interoperability is improving. I think, again, it comes back to the human being sitting in front of the computer screen and figuring out how to make their experience, whether it's the provider or the patient, frankly, navigating all to get to all the information that they need, the simplest and sort of smoothest that you can. There are always going to be hiccups or extra steps or extra clicks as we're sort of on this journey, but figuring out how to make it as seamless as possible. I think what we've learned is that there's certain integrations that are priceless, like you absolutely have to have them, and then there are some integrations that a simple sort of human workaround is fine for now, so that we can open up access for patients. So it's making some of those critical decisions. Some are imperative. In the tele-ICU environment where we serve hospitals across the country, we have to have full integration. We have to have bi-directional physician order entry into the local medical record, and the burden on the physician is great, right? They have to have logins to about 60 medical epics or meditechs or whatever it is. So, with different services, the burden is higher, and some of that you just have to expect. But the user experience and most importantly, probably access to the information they need to do their job and make good decisions should be paramount.
Absolutely. Absolutely. One other question I'm going to point to you, Christie. We all know that healthcare shortages exist and the facts around that. But what do you see now in the future for telehealth workers, particularly for MDs and APPs, full-time careers versus temporary or supplemental work? And I think they're speaking to the flexibilities that exist out there. What do you think the future is going to look like in that space?
Oh gosh, I wish I had that crystal ball. I do obviously think that providers are going to look for more varied opportunities, because they're going to have the ability. I think we already see that when we're looking at trends of those that have started and tried locums positions, existing physicians who have retained their current position, but also maybe picked up a locum position. There's a big influx of those trying that. So I see a lot of, I would say, dabbling in it, but dipping their toes in that to see if they like that kind of lifestyle. So I think we might see a transition there, which is going to mean that we as healthcare networks need to understand what's going to be our future and how we hire and maintain. I see a lot of providers asking for part-time. I think that's going to be possible as well. You could put together doing various things, and that could be of interest to many providers. I also see various opportunities. I think it's going to expand what you're able to do. So outside of the technology, patient-facing technology, things like e-consults, so interprofessional consults. I think this is it's a very simple concept, really. Doesn't really need a lot of technology outside of information sharing about the patient. But it really has opened up different careers for physicians now who want to be that specialist expert and provide ongoing support out to the PCPs in almost real time, to where the patient, they don't necessarily have to see the patient. So just so much opportunity. I think you're going to have people try, providers, especially the MDs, try out different things, and they're going to have more options available to them. So we as health networks have to make sure that we're looking at that as well.
Absolutely. Anything to add, Emily?
I'd just say the nurses too. That I had a conversation with my CEO about virtual nursing, and he was worried about us recruiting, stealing nurses from the bedside to bring to virtual nursing. So we were having this dialogue, and I was like, I mean, they're leaving anyway. You know, this is an opportunity to retain great nurses in a different type of role and still support our patients, you know, and our nursing workforce. So we just have to think, you know, a little bit differently about the problem that is in front of us, and flexibly about how we retain people that we really want to retain, and move people into positions that are good for their stage of life, for their career, and, you know, and be open to that sort of flexibility.
I
We
would
just kicked
add,
oh, sorry.
go ahead.
We just kicked off our virtual nursing yesterday, and that was a fear as well. Like, right, we actually paused it because we didn't want to take from the bedside. However, that retention, I think, is crucial. And then you mentioned as they go through different stages of life. So starting out at the bedside, I think, is so beneficial for nursing, just as it is for physicians. But as you go through different life stages, you're going to want different or need different things. So being able to transition into doing different things is going to be important, and have that. And then we can retain that knowledge, right? Because a lot of what we're doing in a virtual capacity is knowledge sharing, and using that cognitive, recording that cognitive value.
Absolutely. And I would add that we say this all the time, using clinicians up to the top of their licenses. I mean, PAs and nurse practitioners can do a lot, and parsing out the job. Don't think all the time that, okay, this is all physician activity. Traditionally, look at the job and the continuum of care with that patient, and what are the pieces that can actually be done by others, so that you could potentially virtualize part of that. One last question that I see in the chat is asking about the use of telehealth. Should we be utilizing a different term now? Is this kind of out of date? Should we use digital health versus telehealth? I tend to, we've been arguing this telehealth versus telemedicine for years. Now we have a new one. There's 3 terms really. It's telehealth, digital health, and virtual care. And I tend to go down the virtual health space, because I tend to think of digital health as more of the technology element versus the virtual care being the actual health, which is the telehealth, telemedicine. But that's my perspective. What are yours? Go ahead, Emily.
I mean, it's hard because I think everybody sort of defines those words a little bit differently. It's semantics a bit. It's, you know, how your impression, or even how your organization defines them. I mean, we have a big center for telehealth, but I've thought often, you know, gosh, should we call it digital health or virtual care, and I tend to use the words or the terms interchangeably. So, you know, maybe I'd be open to changing my title and what our team is called, as long as it's advancing the mission here, which is, you know, opening up access and serving more patients than ever before, and meeting people where they are. Whatever you want to call it is okay with me. But I think it's about really sort of all of those things, virtualizing, digitalizing, and engaging in healthcare in new and sort of 2023 kind of ways.
Right.
Yeah, I would agree. I think that it's creating more touch points along the continuum, utilizing technology. And, you know, we started out as telehealth, and we moved it, well, virtual care is a little bit broader. Now digital health, is digital health even broader? You know, I don't know. I don't know the right answer. Different people are going to think different things. I think I just want to make sure that we're not put in a box over in the corner, that we really are looked at. And frankly, I think if you look 5-10 years down the road, I don't even think the term will exist. It will just be part
of this before, though.
Yeah. I mean, I'm thinking, you know, it's going to just be hybrid care, or it's just going to be care, right? Whether it's in person or, because it's going to be fluid.
It's part of care.
Yep. Our last question that's coming up in the chat, and then I'll leave it to you guys to do some final thoughts, but they wanted to know your thoughts on cellular connected remote patient monitoring devices like glucometers, blood pressure monitors, etc., that don't need Bluetooth or Wi-Fi. Any thoughts on those pieces of technology?
We largely use cellular based because of some of the digital sort of access considerations that we live in a rural state. I'm from South Carolina. But, you know, I think again, it comes back to the sort of the user experience, and that market is evolving so quickly. I think, what we're using to transmit data today will look very different, and it may even be less than a year. So I think my suggestion would be, when making decisions about those things, think about what works now and how to remain nimble with your strategy, and not focus so much on the specific device or how it pairs, but just that it's able to bring the data in so that your team can look at it and make decisions. But yeah, I mean, we've used all different types of devices and how they pair and how they send information back to us, and that will continue, I think.
Yeah.
That's going to evolve. I think you take it back to texting. I remember I refused to text when you had to do it 1, 2, 3, ABC. I'm like, I'm not going to do it, but it didn't take long for that to evolve. So it was really just understanding the concept of texting and communicating that way. And then the technology quickly came along. And I think that we're going to see that we have some evolution. We have a few years to evolve here around the location monitoring.
I also think it depends on your care site. If you're a FQHC, for example, I think that, you may be looking at the simplest, most cheap options that you possibly could get, because that's the way it goes. So it depends on your care environment. Any final thoughts on the provider space, and anything that you wanted to share that we didn't already talk about? Or do we exhaust it all for today?
Yeah, well, I'd say one last thought, because this did not come up, and I think it's really important, is the patient choice in all of this. I've seen in our health system a real sort of head turn toward what the providers like and what they don't like, and whether they want to do virtual or they think it's appropriate or not. And the appropriateness is certainly an important debate, and each specialty there's going to be differences, and that's a debate that should continue to advance. But I think it's important at a system level, and oftentimes at a high leadership level, to commit to letting the patient decide at the point of scheduling how they're going to engage for appropriate visit types with their provider, because then it takes it out of an individual provider's choice or an individual clinic's choice about how they're going to manage their staff, and it really flips it over to a patient sort of centric model and patient choice. I think providers, or at least some that I have engaged with, tend to think that patients always prefer in person, and that's just not our lived experience. So when we offer, particularly those specialties with a long wait time, when we offer virtual as an option, about 50% say, absolutely, I would love to be seen by a rheumatologist or endocrinologist this week instead of 6 months from now, because I'm hurting or I'm whatever it is. And so I think, that's a very powerful testament to the importance of patient choice, and not getting caught up in our headspace around what this physician wants to do or what this department chair thinks is right, and more about what the market will bear and what the customers want.
We just made that change, and I say that change, but we're taking it, and I the autonomy of a physician is still very important, and I totally understand that. But if we truly say we're patient centric, then we need to make sure that we thinking of the patient and what the patient wants. And I've heard that before said that, well, patients want in person. Well, I think that's the perception, because we're not even asking. So there's that. And then I would close on my thought is, we're making it, we need to make it easy for the patient, but we also need to make sure that we are thinking about the physician and the resources that we're giving them. One thing that has been really critical in success is the kind of support that we offer. So making a physician put in an IT ticket every time something's going wrong isn't going to work. What's going to happen is they're going to throw up their arms and they're saying, no, these patients are coming in because I'm not doing this anymore. And so if we're not providing the appropriate support, that's as real time as possible, there's nothing more frustrating than to try to care for a patient and something to drop. And then we need to figure out how to really help them with troubleshooting in real time, but also making sure it's not onerous. It's not onerous of the physician to have to get that answer.
Absolutely. And I think my final thought on that, to add it to it, is that don't don't put all the burden on the physician. If it wasn't something that they would have done coming in the door, you wouldn't have them go directly to the physician desk and say, hey, I'm here for my appointment. And those things, but any of those things, that's my comment about parsing it out. We're about 4 minutes over time for our panel, but this has been a great discussion, and I think it's been worth the time, and we had a lively chat, and there's still Q&A coming in. So I'm sorry for those that we didn't have time to pick up, but we will try to answer them as much as
Part
possible.
two.
Part two.
Part two.
Part two. We need a part two. Exactly. Thank you so much, Emily, Christie. You guys were great. And everyone that joined, I appreciate it. Have a great rest of your week. Don't forget
Thank
the
you.
recording is available as well.
Thank you.